Welcome to Healing Horizons, Ibogaine Therapy in Mexico. I'm Chris Daniels, your host. Today, we're unpacking dosage, how it's determined, what it feels like, and how it shapes safety and outcomes. Quick note before we start. Ibogaine carries medical risks and must be screened and supervised by qualified professionals. This episode is educational, not medical advice. My aim is to demystify dosing so you can ask better questions, set realistic expectations, and make safer choices if you pursue treatment in Mexico. We'll explore science, protocols, personalization, and how to translate the experience into lasting change. And we'll close with safety checklists. Ibogaine is a naturally occurring alkaloid from Tabernanthe iboga. In the body, it converts into noribogaine, a longer-acting metabolite. Together, they interrupt withdrawal, reduce cravings, and open a window of neuroplasticity where change is easier. Mechanistically, they modulate NMDA receptors, kappa opioid, sigma, and serotonin systems, and increase BDNF, supporting learning and mood regulation. Clinically, people often experience rapid detox from opioids, decreased compulsive drive, and heightened introspection. Noribogaine's tail can last weeks, offering a stabilizing effect while new habits take root. Dosing influences how intensely these mechanisms are engaged and how tolerable, safe, and therapeutic the process becomes for patients. Dosage matters because we're balancing three levers: safety, efficacy, and intensity. Too little, and you may not interrupt withdrawal, cravings, or maladaptive patterns. Too much, and you increase risks like cardiac arrhythmias, prolonged ataxia, or overwhelming psychological content. The goal is a dose that achieves therapeutic targets while respecting your physiology. Dosage also shapes the arc of the experience: onset speed, visionary depth, duration, and recovery time. Remember, bigger isn't better. Outcomes are driven by dose plus preparation, medical stability, therapeutic support, and integration. Smart dosing aims for sufficient receptor engagement with manageable stress on your body and mind overall. Ibogaine comes in several preparations with different alkaloid profiles and strengths. Ibogaine hydrochloride is purified, predictable, and widely used clinically. Total alkaloid extract includes ibogaine plus related compounds. Some find it broader, but potency varies. Root bark is the least standardized and carries higher variability and impurity risks. Reputable clinics standardize dosing by milligrams per kilogram of active ibogaine, regardless of form, to align exposure with body mass. Potency, bioavailability, and batch testing matter. Ask for certificates of analysis, microbial and heavy metal screening, and how the clinic converts TA or bark to an estimated ibogaine equivalent m or kg for dosing accuracy. Most medical teams use a structured protocol: a small test dose to assess sensitivity and cardiac response, followed by a therapeutic flood dose with optional boosters. Representative ranges often fall between 10 to 20 ply monoc in ibogaine, HCl equivalent cumulatively, though some complex detoxes require staged courses. A common pattern might be 2-3 bicremister test, then 8-12 macries, then 2-5 macro boosters as indicated. Timing is individualized based on vitals, EKG changes, electrolytes, and clinical response. Floods aren't always maximal. Gentler stepwise dosing can be safer for certain profiles. The emphasis is targeted exposure, continuous monitoring, and responsiveness to real-time data throughout care. Personalized dosing starts with body weight, but quickly expands. Past substance use patterns inform tolerance and receptor adaptations. For opioids, high daily morphine equivalents or long-acting agents often require careful staging. Stimulant or alcohol histories shape sleep, cardiovascular, and electrolyte planning. Current medications, especially those affecting heart rhythm or serotonin, drive adjustments. Hydration, nutrition, and electrolyte status influence safety and comfort. Acute withdrawal state matters. Arriving overly sick can push risk. We also consider timeline pressures. Rushing dosing to fit travel is dangerous. The safest programs slow down when your physiology needs time, even if the itinerary changes for safety. Liver and heart health are pivotal. Elevated liver enzymes, hepatitis, or fatty liver can slow metabolism and increase exposure. Structural heart disease, arrhythmias, or prolonged QTC elevate risk. Genetic differences in CYP2D6 metabolism matter. Poor metabolizers may need lower, slower dosing. Ultra-rapid metabolizers may clear faster but still require caution. Age influences reserves, hydration, and recovery. Prior Ibogaine exposure can shift sensitivity and Ibogaine buildup. Sleep debt, anemia, and infections add stress. Each factor nudges dose selection, spacing, and monitoring thresholds. Good clinics synthesize all variables, not just weight, and move only as fast as your data allow to proceed. For opioid detox, dosing targets interrupting withdrawal while avoiding stacking during unstable vitals. Staged or split floods are common, with electrolyte support and antiemetics. For stimulants, doses may be slightly lower, with heightened cardiac vigilance and sleep restoration planning. Alcohol-related cases require careful benzodiazepine management, thiamine, magnesium, and seizure precautions. Ibogaine is not a substitute for acute withdrawal management. For trauma or depression, dosing is often gentler, focused on introspection and neuroplasticity rather than rapid detox. Across indications, Ibogaine's afterglow is leveraged differently. Craving suppression in opioid use disorder, mood stabilization for depression, and cognitive flexibility for trauma processing work. Pre-treatment screening is non-negotiable. Expect a 12-lead EKG with QTC measurement, electrolytes including potassium and magnesium, liver and kidney panels, complete blood count, pregnancy test when applicable, and a detailed medical and psychiatric history. Many clinics request recent echocardiograms for patients with murmurs or risk factors. Fasting glucose and thyroid panels can be helpful. Share all supplements, recreational substances, and prior adverse reactions. Full disclosure isn't about judgment, it's about engineering safety. Abnormal results don't always cancel treatment. They guide optimization, referrals, and timelines. If a clinic minimizes labs or proceeds despite red flags, consider that a deal breaker for your protection. Discuss potential interactions openly. Methadone and other long-acting opioids complicate dosing and QTC. Careful tapering and washout are standard. Buprenorphine requires coordinated transitions to avoid precipitated withdrawal. Benzodiazepines can be dangerous when combined with Ibogaine. Stabilization and gradual tapers are essential. SSRIs, SNRIs, MAOIs, antipsychotics, tramadol, and many stimulants influence serotonin or cardiac conduction. Avoid QT prolonging drugs near treatment. Recent heavy alcohol or sedative use raises seizure and respiratory risks. Disclose ketamine, kratom, DXM, or coca products. Bring medication lists with doses and dates. Never stop prescribed medications without clinician guidance. Instead, plan changes collaboratively and safely with the team. Plan timelines honestly. Methadone often needs weeks to months of gradual tapering, sometimes transitioning to short-acting opioids before Ibogaine. Buprenorphine tapers are individualized. Microinduction strategies post-Ibogaine may support stability. Benzodiazepines require slow, physician-guided reductions. Rushing is dangerous. For alcohol dependence, medical detox with benzodiazepines, thiamine, and monitoring should occur before Ibogaine. Only proceed once vitals and electrolytes are stable. Hold stimulants under supervision to baseline the heart. Stabilize sleep, hydration, and nutrition. Build buffer days for travel fatigue. The right pace reduces complications and improves outcomes. If a clinic promises miracles on impossible timelines, reconsider your plan with trusted medical partners. In Mexico, standards vary, so know what to expect. A physician should evaluate you, order labs, and be present or immediately available during dosing. Continuous cardiac and pulse ox monitoring, frequent blood pressure checks, IV access, electrolyte management, and antiemetics are standard. Clinics should have defibrillators, oxygen, airway equipment, emergency medications, and written transfer agreements with nearby hospitals. Dosing should be calculated in mg of active Ibogaine with batch documentation. Staff must be trained in ACLS and recognize QTC changes. You deserve informed consent covering risks, benefits, and alternatives. Transparency and readiness are non-negotiable indicators of a responsible program for patients. What might you feel? Onset often brings body heaviness, ataxia, and sensitivity to sound and light. At therapeutic floods, many experience a visionary or introspective phase, rapid images, life review, or felt guidance, lasting several hours. Nausea is common. Keep eyes closed and minimize stimulation. Lower doses can be quieter and more cognitive. After the peak, there's a long processing period with limited mobility. The following day is frequently the gray day: fatigue, sensitivity, and reflection. As Ibogaine settles, many report calm, decreased cravings, improved sleep, and openness to change, the afterglow. Hydration, electrolytes, and patient reassurance help immensely during early recovery phases. Intensity doesn't equal outcome. Set and setting, your mindset, preparation, therapeutic support, and environment shape results as much as dose. Prepare intentions and practical plans, safe housing, sober supports, and therapy appointments ready. Integration during the Ibogaine window is prime time. Structured sleep, protein-rich nutrition, hydration, light movement, and daily reflection. Therapy modalities like CBT, EMDR, or ACT help convert insight into behavior. Peer groups provide accountability. Build relapse prevention. Triggers, coping skills, and contingencies. Be cautious with unsupervised microdosing. Interactions and overuse can undermine recovery. Respect fatigue, avoid big decisions in week 1, and celebrate incremental, consistent change over the months. Before choosing a clinic, ask, how do you calculate dose, mg of active Ibogaine? What labs are required? Who is the physician of record? How do you monitor QTC, electrolytes, and vitals? What emergency gear and hospital transfer protocol exist? How do you handle methadone, buprenorphine, benzodiazepines, and alcohol? What aftercare do you provide? In Mexico, Ibogaine is unregulated, so standards vary. Vet credentials, partnerships, and reviews carefully. Today we covered mechanisms, dosing forms, strategies, personalization, screening, interactions, safety, experience, and integration. Remember, this podcast is educational, not medical advice. I'm Chris Daniels. Thanks for listening to Healing Horizons. Stay safe.